Let's start now. And I will just say a few words. I wanted to welcome everybody to the Center for the Study of Europe at Boston University, this time in online mode because of the circumstances. We are extremely happy to have here two renowned speakers who have a lot to say on the topic of the day, which is health. So the springboard for our discussion today is a recent book by Sandro Galea. The title is, Well, What We Need to Talk About When We Talk About Health. So Dr. Galea is a physician and epidemiologist and a very prolific author. He is Dean and Robert A. Knox Professor at Boston University School of Public Health. He has held academic and leadership positions at Columbia University, at the University of Michigan, and at the New York Academy of Medicine. He is one of the most widely cited scholars in the social sciences. He has published extensively, and he's the author of a long list of books. In addition to we have another very recent book, which is Pained, Uncomfortable Conversations about the Public's Health, co-authored with Michael Stein. Delighted to have him here tonight. He's also a member of the National Academy of Medicine. So the discussant today is Scott Greer, who is a professor of health management and policy, global public health and political science at the University of Michigan, as well as senior expert advisor to the European Observatory on Health Systems and Policies. Today, he's going to provide us with a discussion of Sandro's book from the perspective of health policies in the European Union, a subject on which he's an expert. In fact, he is the author of a 2014 book entitled Everything You Always Wanted to Know About European Union Health Policies But Were Afraid to Ask, a truly enlightening book. He's also an extremely prolific author, and in 2019 he published Federalism and Social Policy, Patterns of Redistribution in 11 Democracies. His latest book just came out. It's titled The EU After Brexit, and it has been published by Manchester University Press. So with these two wonderful authors, I look forward to the discussion today. Sandro, please. Thanks.
Well, thank you very much, and thank you for having me. Let me share my screen, and there we go. And I wanted to do a bit of a summary of what the book was about, and really it was the book was called, as you saw in the screen share earlier, What We Need to Talk About When We Talk About Health. That was really the title of the book as I wrote it, until the publisher said, well, you cannot really call a book that because nobody will read it, it's too long, so it has to be called something else. Hence, Well was added as a word title. But really, my agenda behind the book was to say we should think about health differently. We should talk about health differently. And while I wrote this book now, I suppose 2 years ago, because it came out last year, I cannot think of a time when the agenda is more relevant about thinking differently about health in the context of what's going on right now during the time of global pandemic. So I wanted to just lead you through some of the concepts that are in the book, and then I look forward to Scott's comments and our discussion. And I did not want to do a talk that was all about COVID. I feel like all our lives are COVID all the time, but I am going to refer to why I think some of these concepts are particularly relevant in a time of COVID as I go through. So with that introduction, let me move to the next slide. Let me just sort of figure out how to do that, sorry, while still screen sharing. Good, everybody still see that? Okay, yes. Daniela, good, okay, very good. Okay, so the book is organized in 20 chapters, and each chapter is about a topic, a concept, and I'm going to just talk about 7 of them here, just to do this in 15-20 minutes. And the reaction I get to these concepts is ranges from everything you're saying is obvious to what you're saying is totally radical, which I take it the truth is probably somewhere in the middle. And I'll start with perhaps the most obvious of concepts, which is health and not healthcare. And this concept is it always baffles me how novel it is to our public conversation. And I've taken to explain this concept by telling this story. And this is a story of blind Willie Johnson. And Willie Johnson was a bluesman, and we remember him because he is, we have some of his records. And he was born at the turn of the 20th century in Texas, and he was born sighted. And when he was a boy, when he was about 7, his mother threw lye in his face, and he became blind in a domestic violence accident. And he grew up poor and blind and black in Texas in the early 1900s. He got married, and him and his wife were living in a small house which burned down, and they didn't have any money. So their house, they went back and they were living in the burnt out shell of the house, even though the house had burned down. When he was in his 40s, blind Willie Johnson got malaria. And this was Texas in the 1940s, where malaria was pretty common, so it wasn't so uncommon. And his wife took him to hospital, and where he was turned away. And it's not clear if he was turned away because he was poor, because he was Black, or because he was blind. But then he died. Now, I tell the story to say, what killed blind Willie Johnson? Well, what killed blind Willie Johnson was malaria. Had he received treatment for malaria, perhaps chloroquine, which is the treatment that we currently keep talking about in the current epidemic, he would have lived. So clearly malaria killed blind Willie Johnson. But the reason I tell that story is because anybody who listens to it recognizes that it wasn't just malaria that killed blind Willie Johnson. It was homelessness, it was poverty, it was racism, it was domestic violence, it was lack of access to care. And that's the difference between health and healthcare. Healthcare is treating his malaria, health is everything else. And of course, both are important, both matter. The challenge is that we often conflate the two. And I sometimes challenge people to say, if you don't believe me that you conflate the two, just try having a dinner table conversation about health with people, with educated people like yourselves. And you'll see within 5 minutes, somebody will use the word healthcare and health interchangeably because we mix these two up all the time. Now, why does it matter that we mix these two up? Well, it matters we mix these two up because we spend disproportionately on healthcare and not on health. The bar on the left here shows roughly what causes health, and medicine, healthcare causes 5 to 10%. Is the green bar of health. Genetics matter. Our physical environments matter much more. Our behaviors matter much more, and a whole bunch of other stuff put together matters much more. The bottom line is that the green bar is how much healthcare matters, and on the right is what we spend our money on. What we spend our money on is all essentially healthcare. So there is this enormous mismatch that we are spending all our money on malaria, even though malaria is just one of the small drivers of health. That's the health and healthcare dichotomy. Let me come to the moment in time to illustrate how this plays out in a moment like this with COVID. This is what we've been doing in terms of spending, for example, on public health emergency preparedness, which as you see has been going down in real funds, which is the red line, and blue funds is in the nominal funds. And every time a disaster happens, you get this green bar. We spend a lot of money on pandemic influenza, H1N1, Ebola, and Zika. You get these bursts of spending. But we haven't been doing nothing about fixing the decreasing public health emergency spending that has been going down over time. We have simply not investing in building the structures that create a healthy world. We're only investing in treatments. And in some respects, putting a whole bunch of money in H1N1, like putting a whole bunch of money in COVID, is spending money on treatment at the population level. Just like at the individual level, that's where we put all our money. So we're putting all our money in healthcare, in sickness care, rather than in health. And this is Massachusetts, by the way, because sometimes in Massachusetts, I think we get pretty sort of high and mighty about these things, saying, well, we got this right. But look at Massachusetts over 15 years. We spend more on healthcare, less than the same on primary, secondary education, law and public safety, mental health, public health, higher education, early childhood education, environment and recreation. So essentially, we've decreased our spending on what causes health, increased our spending on healthcare. So point one, health is not healthcare. And health, what causes health, we underspend on, and we overspend on healthcare. Point two, power, politics, and money are health. And there are so many ways I could tell this story. And notice, I'm not saying power, politics, and money lead to health. I'm saying power, politics, and money are health. They really are interchangeable. And if we ever need to sort of to hear a story to believe that, we can look at what's happening right now with COVID, where the entire story of COVID is being written largely with a sort of political crayons that are all ultimately reflecting power and political lines. But I'm showing you this not just to take us back to the perhaps innocent days of February 26, 2020, almost, I guess, a month and a half, almost 2 months ago at this point, when the president named the vice president to lead the coronavirus effort. But to show you that this was the front page of the Times that day, lower down on the front page was this, that a gunman killed 5 co-workers in Milwaukee. And if there has been any story that has been of health that has been so influenced by politics and money in the United States in the past several decades, it's the story of guns and how we've treated firearms. This is our spending on guns. The purple is our spending on gun rights. The orange is our spending on gun control. And what I want you to see is a timeline And you see the Sandy Hook Elementary School shooting, horrific shooting in Sandy Hook, which resulted in a lot more spending on gun control and efforts at gun control legislation, but commensurately, a lot more spending on gun rights. Our story of guns, our national story of guns, is entirely been written on a landscape of politics and money. And it's a story that doesn't exist without that. Our interpretation of the Second Amendment through a 5-4 Heller Supreme Court decision was entirely determined through a makeup of a court that had been determined to the interplay of politics and power over the past several decades. And it is a story that ultimately results in a health, in health consequences that is all a feature of politics and money. Now, I could tell you this without talking about guns. Guns are always controversial. Here's another one. Our investment in food subsidies. This is the prevalence of obesity by state subsidies. These are quartiles of subsidies, and we see is that by state, the states are more obese the more we subsidize corn, which results in calorie-dense, nutrient-poor foods. And one could talk about this in many different ways. So number 2, power, politics, and money are health. Number 3, there is no health for the many if we exclude the few. Now, this was perhaps always the hardest point for me to make when I've talked about this book in the past year. And now in a time of coronavirus, well, perhaps it's become the easiest point to make. Because is there ever been a time when it's been clear to us that our health is interlinked, that the health of all of us is linked to the health of a few of us? Now, thinking about this goes back to sort of utilitarian thinking. This is Jeremy Bentham, the father of utilitarianism. This is Jeremy Bentham's mummified body outside University College London, which in utilitarianism, you're dealing with, can we count the health benefits of the many? And that approach of utilitarianism results in us privileging the majority and putting aside the needs of the minority because they ultimately do not count that much to our health, collective health utility. Well, try telling that to a virus. Try saying to a virus that, well, you're only going to live within some national boundaries and you're not going to come to other countries, which of course is absurd. This is the map of the world. This was just a couple of days ago when I went to get this map showing, of course, coronavirus all over the world. A spread of a pandemic illustrates how the health of a few is intimately linked to the health of the many. And there are many different ways of telling this story. One of our responses to the virus has been the enormous economic shutdown, the enormous economic slowdown, which has resulted in a stock market crash, which of course affects relatively few people, but ultimately it affects mostly the economic slowdown, the poor and the marginalized, who are ultimately going to be most hit by coronavirus because these are the jobs that are being lost. They are jobs that are lower paid, people without sick pay, people who are single parents, people of color. And this is ultimately the few that are being hit by efforts to protect the many, once again, because of a compounding of a problem that went from the few to the many. Ultimately, we are all in this together. And part of what we're trying to do here is recognize that my health and your health is interlinked and that we need to act in such a way, and I'll come to this in a second, where we recognize that. Here's one simple way of looking at it that's not infectious disease. This is children killed by motor vehicles. I have children, many of you have children as well, God forbid they're ever injured. And we think to ourselves, well, I'm a good driver. It's nothing's going to happen with my kids. But 10% of kids killed by motor vehicles actually are pedestrians, killed by alcohol impaired driver. They have nothing to do with them whatsoever. So this just gives a sense of how our health is interlinked. And I could make this case many other ways, but surely that case is best made in a time of coronavirus when we realize that we cannot afford to have small groups of people who are pockets and reservoirs of infection who are spreading infection when in fact we can actually be better at that, protect small groups of people, protect a few so we can actually protect the many as well. Point 4, we need wisdom and humility to understand health. Yes, we certainly need wisdom, but we also need humility. We need humility to know what we do not know, to understand health. Because ultimately, health is a product of 4 forces. It's a product of blood and green phlegm and yellow phlegm and bile. And really, our health is the balance of those 4 forces. And if those 4 forces are out of whack, your health is out of whack. So when you have a fever, the reason you have a fever is because you have too much blood, which is why we drain blood from you when you have a fever using leeches or cutting using a blade. Now, as I'm telling you this, those of you who are paying attention will start wondering whether they've descended into a talk in the 19th century. And the answer is yes. But why am I telling you this? I'm telling you this because this was our received wisdom of what caused health for about 2,000 years. This was 2,000 years of knowledge. So anytime but the past 150 years, had I just said what I just said, you would have thought, okay, yeah, well, that's true. That's exactly what we know, and that's exactly what we do. Why am I saying this? I'm saying this because there are many ways in which we see health and see it wrong. There are ways we saw it wrong 150 years ago, and there are ways in which we see it health wrong today. So let me take an example. What are the leading causes of death? This is the CDC website. Leading causes of death are heart disease, cancer, chronic lower respiratory disease, etc. Those are leading causes of death by counting the cause of death. Is there another way of counting the causes of death? Of course there is. Suppose we ask ourselves, what are the leading causes of death by looking at the fundamental social forces that drive health? Going back to the Willie Johnson story, this essentially is counting malaria cases, right? Heart disease, cancer, the things that kill you. What if I actually went back and said, what about his housing, his education, the racism? What if I count all of those causes? Well, you can do that. This is here, first of all, I can count his behaviors, tobacco, poor diet, alcohol consumption, another way of counting causes of death. Or I can count the foundational factors, low education, poverty, low social support, area level poverty, income inequality, racial segregation. And by the way, these causes are relatively equivalent in terms of amount because they ultimately add up to the number of people who die in the country. The number of people who die from low education is the same as the number of people who die from, for example, heart attacks. Now, you're saying, okay, well, those are different ways of looking at things. I agree they're different ways of looking at things, but these different ways of looking at things really matter. Because if you say the leading cause of death in the country is heart disease, you are going to create an institute of heart research that is a premier biomedical national heart, lung and blood research institute in the world. And that's exactly what we've done. If you say, well, the leading cause of death is low education, you should be creating an institute of low education and health, which we have not done. So our understanding of health, our lens on health, really matters for what we spend our money on and how we approach health. Thinking that heart disease is the leading cause of death, there's nothing wrong with that thinking. It is accurate thinking, but it's equally accurate. Say a leading cause of death is tobacco smoke, or equally accurate, say a leading cause of death is low education. And how we see health determines what we spend our money on and the lens through which we approach health. So that's why it requires wisdom to separate these ideas out and the humility to know when we're wrong. Number 5, all of this leads to us needing to understand health as a public good. We need to understand that health is something that does not lend itself to market production, purchase, or sale. It must be provided for everyone, it is provided for anyone, and it must be paid for collectively or cannot be had at all. This is from The Affluent Society, which is sort of the classic book about this. Now, of course, when you look at that definition, you realize that in the US, that is exactly not how we think about health. We do not think about health as something that lends itself to market production, purchase, and sale. We do not provide it for everyone if we provide it for anyone. And it's certainly not paid for collectively at all. And of course, by not doing that, we expose ourselves to the kind of conditions that lead to the proliferation of a pandemic like what we're seeing now in a time of coronavirus. Now, you might say, okay, well, it's a stretch. It's a stretch for us to do that on health. But is it such a stretch? Is it more of a stretch than taking a park like Central Park right in the middle of Manhattan, one of the 2 most expensive real estate markets in the country, and saying, this is a public good? I mean, maybe we shouldn't treat Central Park like a public good. Maybe what we should do is just divide up Central Park into little tiny plots, and everybody who pays taxes in Manhattan gets their little tiny bit of park. And that's the only little tiny bit of park they can sit on. Now, you might say, well, that's ridiculous. But is it? Is it any more ridiculous than saying, I buy my own health, you buy your own health, and my health is my problem, your health is your problem? It doesn't fit when you recognize that our health is also interconnected. When you realize that the health of the many is linked to the health of the few, you realize that the only way to actually achieve that is by treating health as a public good the way we treat parks, the way we treat the post office, the way we treat fire stations. These are all forces that we treat as public good, and there's no reason why we don't treat health also as public good. Of course, if we don't, we get into problems like we're having right now with COVID. And this is actually, I like this map. This is looks at social connections between US zip codes and just one zip code. This is the East Village in New York, zip code 10003. And what you see is essentially all the country is connected to one zip code, quite different levels of connectedness, but we are so interconnected that to have the conceit to think that my health and your health are separate is really a big mistake, and it is not how we should be thinking about it. And if there's ever a time to see that, it's now. It's a time of COVID. 6, All of this ultimately has to be driven by compassion. Compassion needs to be at the heart of health. And I want to be clear what I mean by compassion, because you often hear the word empathy tossed around when you talk about health. And compassion is a higher order way of thinking than is empathy. Empathy means I care for your health because I can imagine what it's like to suffer the way you do. Compassion says, no, I don't need to think of what you're going through happening to me. What you're going through should be unacceptable because we want to build a society better than that. Boston University's perhaps most famous alum is Martin Luther King Jr., who wrote, "True compassion is more than flinging a coin to a beggar. It comes to see that an edifice which produces beggars needs restructuring." What compassion is a way of seeing that the world can be a better place. And if the world can be a better place, we should make it a better place because it's the right thing to do. And perhaps there is no better example of this than the way we deal with guns, coming back to guns. This is what happens every time there is a shooting in this country. You get a lot of thoughts and prayers. That's the opposite of compassion. That's the opposite of compassion. Compassion says, what is the problem and how do we fundamentally fix the problem? Now let's come back to coronavirus, just because this is the moment that we're living in, and say, can we think about coronavirus through the lens of compassion? This is world leaders calling to the end of stigma and hate during coronavirus outbreak. That's the opposite of compassion, stigmatizing and hating others because of coronavirus, which suggests how far we have to go towards a world where health is seen through the lens of compassion. I want to tell this one story from another epidemic. This is after Ebola, where persons of the year were the Ebola fighters, which undoubtedly persons of the year this year will be all about coronavirus. This is Salome Karwa, who was an Ebola survivor. What you see there, she's an Ebola survivor, lost both her parents to disease and now counsels patients in Liberia. Salome herself actually had Ebola. She was a nurse, and the remarkable story is that despite having had Ebola, surviving Ebola, then she went back and volunteered to look after more Ebola patients. Really remarkable person. When she was pregnant with her child, she had an obstructed labor, and her husband took her to JFK Hospital in Monrovia, which is the main hospital in Liberia, and she was turned away from hospital and died. And the reason she was turned away from hospital is because she had Ebola. And the reason I give that example is because when we do not approach health from a place of compassion, when we are trying to make decisions on things like, well, have you had Ebola? Have you not had Ebola? Are you then allowed in hospital or not? We lose sight of the fact that nobody should be denied entrance to a hospital. Nobody should be denied entrance to a hospital. And we only are clear about that. We only make sure that that does not violate our norms of human decency and the elevation of health as a central principle by having compassion inform how we deal with health. My last point, and then I'll turn it over to Scott, is we should be free to choose health. One of the challenges I get at this point in my talk is, well, I'm not understanding the American ethos of freedom and choice, and we all choose to be unhealthy, and we should, and everything I'm saying is against choice. It's true. I actually don't think it's true. I think even though there's this American myth that build on foundational documents that we actually choose, we keep forgetting something very simple, is that we do have choices, but we always talk about freedom to, and we do not talk enough about freedom from. And we want freedom to do things, yes, but we also want freedom from unnecessary bad things. This is obesity. This is the amount of obesity around us, and we don't choose obesity that makes us unhealthy. And what's driving our obesity? What's driving our obesity principally is a change in the number of calories of food. Look at bagels. Bagels were 140 calories 20 years ago. Today, they're 350 calories. So God help you if you had a bagel for breakfast. If you had a muffin, there's no hope for you whatsoever. It was 210 calories. Now it's 500 calories. Not to mention French fries that have tripled the number of calories. This is what's driving the obesity epidemic. And should we not want freedom from unnecessary obesity and unnecessary heart disease? We do not necessarily choose this. We may choose our food, but ultimately we are choosing from a set of choices that are fixed for us that determine what we have freedom from. Have we done this before? Of course we've done this before. This is one of the biggest triumphs of public health of the past 100 years, which is the decrease in deaths from motor vehicles. We drive a lot more now, that's the green line, and we die a lot less. And now why is that? Is that because we have chosen to drive better? I mean, this is in Boston. You all know that our driving is not that good. No, this is because we have chosen to die less. We have chosen freedom from dying unnecessarily. And we have cars with seat belts and airbags and shatterproof glass and laws against drunk driving. That is what has bought us freedom from dying in our car. So I want to conclude. I want to conclude about thinking differently about health. And I'll conclude with a metaphor. And it's a metaphor about my favorite sport, which I think is sort of appropriate given that this is has a European perspective on it. And my favorite sport is by far soccer. And for many years in America, I was on the defensive about soccer, but now America, of course, has the world's best soccer team, which is the US women's national soccer team. And the reason I'm showing this story is I'm showing a soccer team is because I think soccer is a very good metaphor for how we should be thinking about health. In soccer, there's a goalkeeper. That's the woman, Alyssa Nair, the woman wearing the black uniform. And then there are 10 other players. And 10 players can only use their feet, hence football. And the goalie can do anything she wants to stop the ball from getting into the net. And the other players can only use their feet. And by metaphorically, the goalie is your doctor. The goalie is healthcare. The goalie restores you to health if you're already sick. The goalie should be your last stop. The goalie is treating malaria for Blind Willie Johnson. But the other 10 players are the forces that generate health. They are safe housing, good food, clean air, drinkable water, gender equity, livable wages, fair economy. They are the forces that ultimately generate health. And you're not going to win at soccer if you have the world's best goalie. If you have the world's best goalie, you are not going to win if that's all you have. You need the other 10 players. And that's ultimately what health is about. Health is about the full set of teams. And this is not an anti-doctor argument, not at all. It simply says, I mean, you want a good goalie, you need a good goalie to win. But if you're investing all your money in the goalie, which is what we do, you are never going to win. And what we're seeing right now, and I'm happy to talk about COVID, which is on all our minds, is we are reaping what we've sown for many years, which is where we have built a country without a good 10 players, where we've invested all our money in the goalie and we have been playing defense. We have been playing defense, trying to keep the ball out of the net ever since this pandemic has hit us. That's it. I will stop here. I really look forward to Scott's comments and to all your questions and discussion. Thank you for having me.
Thank you so much, Sandro. This was wonderful. I came across your book a few months ago, and as I do European Union studies, I saw ways in which your talk matched perfectly some of the problems there, and in other ways, the match was incomplete or was, partial because of the way in which categories are drawn over there. There we have the issue of federalism, which is drawn differently, so that we're dealing with public health, the European Union cannot do much. So the European Union is always trying to think of health in more and more creative ways as to get at something on which it doesn't have direct powers.